Ventilation management. Here again is Dr. Marshall.
Thank you very much. As she mentioned, we'll be talking about ventilator management. I'm going to try to make this simple, and this is not designed for a critical care and intensivist. This is sort of designed for someone in general practice, and we'll talk about all these fancy modes, and I'll try to highlight areas in the way this might be brought up on an examination and how that will come out in clinical scenarios. Have nothing to disclose financially. So on this lecture, we'll talk about the origins of mechanical ventilation, the indications, and this is probably one of the areas that's important, is who needs the ventilator. Then some of the basics of how the ventilator works and the different modes. We'll touch on some of the newer and alternative modes you may have heard about and some of the buzzwords that go along with that and some of the things that may trigger answers as you see what they want to go. There's a few different concepts that have come to play that have really changed over the last 10 years, and I'll try to highlight those as to where things have changed from when we all trained. And then talking about a little bit of some of the complications, ventilator-associated lung injury, pneumonia, and then some strategies for weaning from the ventilator. So first, the origins. The first ventilators were the iron lungs or negative pressure ventilators. Remember that the lung in a normal physiology is a bellows system where it's actually the opening of the chest wall that has the lungs open. So it's always a negative pressure system. So the pressure in the lungs should never, ever be really above zero. The reason I highlight that is because that's where all the problems lie, because we are using positive pressure ventilation now, which is completely opposite of the way we're designed to function as humans. Here you can see this came about during the polio epidemics, and there at the bottom, Rancho Los Amigos Hospital back in 1953 was just child after child with polio on these iron lungs. Positive pressure ventilators first came in 1955 at Mass General, and this is now the modern standard for ventilation. For question, causes of hypoxia include all the following except A, physiologic shunts, B, anatomic shunts, C, impaired alveolar capillary diffusion, and D, hyperventilation. That's correct. Most just got that. The hyperventilation will cause low CO2, but not hypoxia. So indications for mechanical ventilation. Who needs this? We use this all the time. We use it for general anesthetic, for procedures, for patients that fail to protect their airway. This may be someone who presents to the trauma bay, lethargic, suspected traumatic brain injury, and a Glasgow Coma score of less than 8 is the typical number we say in trauma, and ATLS is if it's 8 or less on the GCS, you need to go ahead and do that. Other causes might be someone with huge, massive GI bleed and hematemesis or other injuries that may cause that. Then a failure to clear secretions. Some people just can't cough and can't manage these. And then respiratory failure, and that falls into two classes, hypoxemic respiratory failure and hypercapnic respiratory failure. That becomes important in how we set the ventilators and how we adjust the ventilators later on. Finally, respiratory failure is hypoxic is a failure to oxygenate, PaO2 of less than 60. And that can be due to a lot of things, physiologic shunting or anatomic shunting. Again, physiologic usually have to do with pulmonary edema, some sort of issue in the lungs, pneumonia, something there. Anatomic shunts are usually from birth and congenital. And then impaired alveolar capillary diffusion. Here we have just something is sitting in those alveoli other than an airspace, whether this is proteinaceous material, pneumonia material, pulmonary edema fluid, something. And then hypoventilation. The patient's just not breathing. So shunts are areas where there's alveolar perfusion, but it's not ventilated. So something is occupying that. You're getting blood there, but it's not being oxygenated. This can be, again, pulmonary edema, pneumonia, atelectasis, and then the anatomic congenital heart defects. Shunts cannot be overcome by supplemental oxygen. Again, The reason for the problem here is that you're not getting anything, any air or gas to that alveoli, so simply increasing the FiO2 and doubling it is not going to help you in a situation where you're not getting that air to the interchange membrane. We have dead space ventilation. There is anatomic dead space, and this has to do with that volume of each breath that sits in the trachea where there's no, or the main airways where there's no alveolar tissue. It's normally about 100 to 150 cc's in most people, and this is that portion of respiration that really just is not getting to the active portion of the lung. And then pathologic could be pulmonary embolism, where you have an area where there's now no regional blood flow, but you're oxygenating that area quite well, even though it should normally provide for gas exchange, it is not. Dead space can be overcome by supplemental oxygen because those areas where you are getting ventilation will respond to having more oxygen. So these are the zones of West, back from physiology days. Zone 1 is the uppermost portion of the lung. In this area, you have the alveolar pressure is greatest, then the arterial, then the venous. So this is an area of dead space ventilation. Because your pressure in the alveolar is greater than that in the vasculature, you're going to have air but no blood. Zone 2 is where most of our normal respiration occurs, and this is the area where the arterial pressure is higher than the alveolar, and that is higher than the venous. So you have both arterial, you get blood, and air to the same place. In zone 3, here at the dependent portion in the base, the arterial pressure is then higher than the venous pressure, then the alveolar. So the blood shunt, this is a shunting area because you simply go from the artery to the vein without having any gas exchange. Respiratory failures, so again, hypercapnic is a failure to ventilate. This is PaCO2 greater than 55. This can be due to a lot of things. This could be due to the nervous system, if you have whether it be some sort of diaphragm dysfunction, spinal cord injury, can be thoracic cage in the elderly, calcium continues to deposit and the muscles become stiffer and you have a very much increased chest wall loss of chest wall compliance. And then the respiratory muscles, whether this be a viral pathology or some sort of other issue, can also cause problems here. So respiratory failure, some of the definitions. Respiratory rate greater than 35 breaths per minute. Minute ventilation of less than 10 liters per minute. Unless this is a very small person, they're not simply getting enough minute ventilation to handle their CO2 production. Tidal volumes of less than 5 to 10 cc's per kilo, or respiratory clinical deterioration. In the most part, what the teaching is, if you're sitting at the end of the bed looking at a patient, you think, I wonder if I should intubate this patient. The answer is probably, I need to intubate this patient right now. So if they present something that suggests that maybe you should be intubating, that's your next step. So you have oral tracheal intubation. Remember C-spine precautions in the trauma bay or in some post-op patients. Nasotracheal, this is not a favored use. This is something that more anesthesiologists do. It's a blind procedure. The patient has to be breathing on their own, and you don't want to do it with any facial or nasal fractures. It's very uncomfortable. Again, this is an awake patient breathing, talking to you, who you're trying to get a tube down their nose into their airway. So again, not a first choice. So always pre-oxygenate, even if the sats look like they're, say, 98, 99, 100. Go ahead and put them on as much oxygen you can and bag valve at full 100% oxygen delivered. This will increase that PaO2 to the point where it's 3, 4, 500. What you want here is this gives you time. Because that's going to take a long time to go away. This is the same way. I remember when we do apnea tests in brain deaths, you pre-oxygenate them up to this level, and they can go 10 to 15 minutes without being on the ventilator, without having their sats compromised. So you want to buy yourself that time to intubate there. You need suction, you need the correct medications, an ambu bag, and a mechanical ventilator handy. You don't want to just intubate somebody and then take someone out of the game. So these are all things you kind of want to make sure that they're there and that they're functioning. One of the most common things people have is they get that laryngoscope and they throw it in after they're paralyzed and the light doesn't work. And it's not very helpful in that situation. So test all of these things and also make sure your suction is functional and not just to some dead canister on the wall. So there's all sorts of adjuncts and accessory equipment, capnography, bronchoscope may be helpful, difficult airway tools in a cart. There's intubating LMAs. There's GlideScope now with video laryngoscopy, which is becoming sort of the standard of care now, especially for those that don't intubate a lot because it allows vision and allows someone else in the room to see what you're doing. It's nice to have anesthesia at least on standby or around the corner or somewhere near the facility. And then have the tools to do a surgical airway, and whether that's just simply a 15-blade or one of the newer percutaneous kits, either of those should be handy. So avoid sedatives and paralytics unless you can ventilate adequately. You want to make sure that you can bag them and get a seal, because there's going to be that point after you sedate where you have to bag and oxygenate prior to intubating for some period of time. Always have a backup plan of what you're going to do next and make sure it's available. Be able to rapidly switch to that surgical airway if needed. And then finally, for a cricothyroidotomy, that can be done percutaneous or open. There are nice new kits that allow you to very rapidly put in, using Seldinger technique, an appliance. The problem with just sticking that 6.0 ET tube down there is that someone has to hold it. It goes into a depth of about 4 centimeters or 5 only before you're almost at the carina. So someone is now stuck holding that in place until you get a definitive airway. So it does get you through the immediate situation, but it's not optimal. Most common error here when doing that is to take that 6.0 tube and to put it into what you think is a normal depth. Remember, you're all the way down here from the mouth, so it only has to go in a few centimeters. Right main stemming is quite common. And so if you end up doing this and suddenly you can't hear breath sounds, you've probably right main stemmed. Tube verification, you have end-tidal CO2 detectors, auscultation. You can repeat with the laryngoscope and just look and make sure it's going down between the cords, or get a chest x-ray and look. No technique is completely 100% adequate, as with all things. Question, oxygenation is controlled by all of the following except A, FiO2, B, PEEP, or positive end expiratory pressure, C, I to E ratio, or inspiration to expiration, and D, respiratory rate. That's correct. Most of you got that. It is the respiratory rate. This respiratory rate and tidal volumes drive the ventilatory side of it and affects CO2. So just the basics here. The slides aren't advancing. Okay. So for oxygenation, the FiO2, or the fraction of inspired oxygen, is the simplest maneuver to quickly increase the oxygen. You do see some oxygen toxicity above 60%, but that's in the long term. If you got a hypoxic patient, set it at 100% and get them intubated, and that's fine for a while until you get control. You just don't want to stay up at that point for days. So you can have inadequate oxygenation despite 100% FiO2. Where do you go next? That's usually secondary to some sort of shunting, whether it's atelectasis, pneumonia, CHF, or pulmonary distress syndrome like ARDS, where the alveoli are filled with fluid. This is the effects of PEEP, or positive end expiratory pressure. You can see this lung here. As the PEEP, what that does is sets a basic, instead of the end expiratory pressure being 0, you set it at, say, 5 or 10 or something like that. So it maintains the alveoli open, and it helps with time to completely recruit these lungs by never letting them completely collapse. This will recruit all of those collapsed alveoli and get you and maintain them in the open position. It also will prevent some shearing injuries, and we'll talk more about that later. So another trick for oxygenation is the inspiratory to expiratory ratio. Remember, normally it's about 1 to 2, meaning we 1/3 of the time are inspiratory and then 2/3 of the time are in expiration. You can reverse that ratio and spend about 3 to 1, say, of the time inspiring so that you get more oxygen there. With that, you'll have to allow some permissive hypercapnia. The lungs will usually not completely empty during these inverse ratios, unless you have a very slow rate. The respiratory rate is, again, targets ventilation, and this is what we're doing with CO2. Remember that ventilation efficiency decreases with respiratory rate increases. Remember, each portion of your breath goes to dead space in the trachea and the other airway. So if you're breathing 50 times a minute at 200 cc's with 100%, you're really only 50% efficient with each of those breaths. You can achieve the same if you, say, breathe 300 at a much lower rate, or 400, where your fraction of dead space is, say, 10 or 20% of each breath rather than 50% of the breath. So low tidal volumes, rapid rate, although you may get the same minute ventilation, the fraction that's going to dead space ventilation is much higher as your rate goes up. So you will eventually lose efficiency, and all the numbers may make sense. Like, say, we still have a minute ventilation of 10. If that's achieved by having half of that go to dead space, it's really effectively only 5. Tidal volumes can also do this. Remember, there's a volume trauma risk. You don't want to inflate the healthy alveoli, and we'll get to more of this later and why we choose things like low tidal volume ventilation. So when we ventilate, each breath goes in, you see the peak inspiratory pressure is that initial first peak, and then the P-stat, or the plateau pressure, follows. This is where you get barotrauma or pressure trauma related. And then you can see the PEEP here, it's set at 5, and that's the level where you never allow it to go below. So that by never allowing it to go to 0, the alveoli should hopefully never collapse. You keep just enough there to keep them stented open. The way to think about that is when you're blowing up a balloon, what's the hardest part? The first breath or the last? It's getting it to open. You have to have huge amounts of pressure to get it to pop open, but once it does, it becomes easier to inflate. The alveoli work the same way, so you want to avoid that high pressure that's needed on a closed alveolus and keep it open with PEEP. There's additional means to decrease CO2. Pressure support for spontaneous breaths, and this means when they're on the ventilator, you give them a little more insistence when they're breathing on their own. You can decrease muscular activity in seizures, sometimes paralyzing a patient if they're in status, stopping the seizures. So this is solving the problem on the production end. Also, dietary. This is not a problem anymore since we've switched nutrition to be about 80% of goal calories. It used to be the old hyperalimentation, where you're putting so much glucose in that you made CO2 and the patient couldn't come off the ventilator because of all the sugar you were feeding them. So adjusting that and controlling hypermetabolic states where you're just having a lot of activity. So just in looking in summary on those, good case scenario might be to present a patient who's on the ventilator and has a high CO2 or prolonged acidosis, and they might give you a choice of 5 maneuvers. You know, which of these would be the best to compensate for this high CO2? So look for something that affects either the ventilation, so you want to do the rate or the volume in those cases. If they're looking for tricks to combat hypoxia, and we'll talk about some more, you turn up the FiO2, increase the PEEP, and those things first. So looking at some of the modes of mechanical ventilation, the first of these is continuous positive airway pressure. These are sort of like the machines that people use at home for sleep apnea. And this basically puts a preset pressure into the circuit at all times. So you might just say, I want a pressure of 5 millimeters mercury. This stents the lungs open, but it doesn't change. It's just you have that pressure. It might be 10 throughout the ventilatory cycle. You just maintain things at a little bit higher baseline pressure. This, again, serves to keep alveoli from collapsing. It results in a better oxygenation and less work of breathing for the patient. We commonly use this as just a way to assess whether a patient's ready to ventilate, because this is basically providing minimal or no support, just enough support to overcome the resistance of the endotracheal tube. You just can put them on this while they still have the tube and see how they do and determine if they're ready for that tube to come out. The PEEP can be set like 5 to 10, which is about enough for physiologic and to overcome because of the narrowness of the endotracheal tube and the length, there is some resistance to airflow that you need to overcome to get it more normal. BiPAP, or bilevel positive airway pressure, again, is very similar to CPAP, only this time you set a high pressure and a low pressure. So you would set a PEEP, which is that baseline pressure that's always there, and then a different pressure for the inspiratory pressure, and this would be basically can be set by the clock. or set by patient inspirations. And so this you might say, I want it at 5, but when the patient takes a breath, increases to 15, so it really supports that breath. So 2 levels of pressure in there. It's inspiratory and expiratory to allow gas to escape. This can be spontaneous, it can be timed, or a combination of spontaneous and timed. This is where a lot of confusion comes in on all these different ventilator modes that can be sort of confusing, but it doesn't need to be. So some of the, there is a way of delivering this non-invasively, and this is with the face masks, the CPAP mask or the complete covering. This is a useful adjunct. Some people will just be extubated straight to the face mask when they're not quite ready, but you think the tube can come out to help wean from the ventilator. It can be used to prevent ventilation sometimes. This is really good for like a patient in flash pulmonary edema. Giving them that extra pressure for a time while the Lasix kicks in can sometimes keep someone off the ventilator. It's not your great long-term solution, but some people where you have an acute problem that you can fix pretty readily, this is great as a bridge. Again, COPD exacerbations, usually medical rather than surgical issues. So the ventilator can be driven either by setting the pressure or setting the volume, and so with each breath. And just remember that we have those 2 options. You're either telling the ventilator to give a fixed amount of pressure, or you're telling the ventilator to give a fixed amount of volume of the breath. And that's where a lot of these nodes. So in these pressure cycled modes, you have pressure support and pressure control. Pressure support is just simply uses the triggered by the patient's own effort. So when they initiate a breath and the pressure goes negative in the system, they get a certain amount of pressure. You might say 15 millimeters of mercury. This is akin to, if you've ever tried a ventilator, breathing with a fan in your mouth. You start a breath and suddenly you get much more, and it's much easier to breathe. So the work of breathing here is minimal. You get a much deeper breath for less inspiratory effort. So it's a nice assisting mode. It is limited by pressure. You've set how much you're going to give, and so that's all that's there. And then when the patient starts to exhale, when the pressure goes, it'll just let them exhale and fall back to that baseline levels. This affects inspiration only. So pressure support alone, when you're not quite ready to extubate, this is that spontaneous breathing trial mode when you want to just see how the patient does and how they fly with minimal or no support to assess your readiness. It does augment tidal volume. So if you've got someone who's weak and a little bit frail that just can't get that volume that they need, this will help them get there without being so unnatural as the more aggressive positive pressure modes. Here, the sedation requirement, this is the most comfortable of the modes and requires the least amount of sedation, which is why they're important, so you can get somebody awake. Looking at a standard control panel here, you can see this is what pressure support looks like. In this particular example, you can see on the top is the airway pressures, and the baseline there in blue is at 5. That's the PEEP level, and the peak there at the top is the pressure support breath. And in this instance, it's set at 10 of pressure support. So you have 5 of PEEP plus 10 of pressure support. You go to a peak pressure of 15 millimeters of mercury. When you look at the flow, it's just standard in and out flow, and the tidal volumes move on a typical sinusoidal thing. So this is the patient driving all of these breaths. They're just breathing at a rate of 20 or 30. They get this extra pressure, and they get a little bit more tidal volume. So someone who was breathing 35 to keep up, now you give them pressure support, might breathe 20 and be more comfortable. Pressure control is kind of akin to, this was the earliest modes of ventilation, like driving a stick shift. Basically, you have pressure in the tube, and in the old ventilators, it was basically just a pressurized system, and you turned a valve on and off. And pressure went in, and you turned the pressure up, and the patient got a breath. You turned it down, and the breath was allowed to escape. This can be, usually it's time triggered, which just means you set the rate at 15. Every 4 seconds, you're going to get this pressure. And so what you're dialing in is the pressure. What is determined, or the dependent variable, is the volume. So you don't know what volume the patient is going to get. You're just saying, I want you to give 30 millimeters of pressure this many times a minute, and that's what you're going to get. So this is good to avoid barotrauma because you're pressure limited, and you can avoid some of that. Again, inspiration only is affected. This requires frequent adjustments because as the patient is in sickness or health and as the lungs lose or gain compliance, that pressure of 30, on one day might give you a tidal volume of 500. As their lungs get better, that might give you a tidal volume of a liter. And because this is time sensitive and not driven by the patient, you can rapidly go into hypo or hyperventilation situations because that tidal volume and your minute ventilation will change as your situation ebbs and flows. Question, which ventilator mode does the most work of breathing? Means makes it easier for the patient. SIMV, which is synchronous intermittent mandatory ventilation. B, airway pressure release ventilation. C, assist control ventilation. And D, pressure control ventilation. The answer here is assist control, and as we talk about that, I'll explain why that does it does all the work of breathing for the patient. So these are volume cycle mode. Again, we just talked about the pressure cycled modes where you set a pressure and the volume is whatever it is. In these, you set the volume that you want delivered, and then the pressure is going to be the dependent variable. These include a control mode, in which you just deliver the breaths. An assist mode in which the patient triggers the breaths and all you do is assist the breaths that the patient initiates. Assist control has both a time factor or a minimum, so you might set that at 15. But if the patient wants to breathe 20 in assist control, they get 20 full ventilator supported breaths. So every single breath in assist control is assisted, whether it be spontaneous or timed. Intermittent mandatory ventilation is you just decide, again, with a time intermittently when to achieve that breath. The difference here between this and assist control is that you set it at 15, they get 15 delivered breaths. If they try to breathe on their own in between, there's no support. So that's the difference here between IMV and AC is what happens on the breaths that the patient initiates as opposed to the ones the machine initiates. And then synchronized intermittent mandatory ventilation just means that it's instead of a time cycled intermittent, meaning like a metronome every so many seconds, this one triggers with the patient. So when they decide to take a breath, they get that breath. So it's a little more ventilator synchrony and a little less sedation required. Again, being forced to breathe in when you feel like breathing out is miserable, and so the patients require a whole lot of sedation for this. Sir?
How then is assist control different from synchronized intermittent?
Again, we'll go over some of these settings again, but it has to do with what's delivered on the extra breaths. When the patient triggers a breath above your set rate, in assist control, the ventilator delivers a full supported breath. In IMV, it might deliver nothing, or you can add pressure support and it delivers a little pressure support, but not the full volume. Again, control mode, this is just the simplest. You just decide, I want this many breaths. The patient cannot overbreathe the ventilator. Miserable. Assist mode means sort of different. Again here, the patient initiates all breaths. They control the rate. But the mechanical ventilation delivers a preset tidal volume every time. So you say, I want you to give a 500 cc breath. Every time they initiate, they get a 500 cc breath delivered by the ventilator. Assist control is in assist mode, meaning that all it is going to do is trigger that breath when the patient wants it, unless they fall below a certain threshold. So you might set this at 15. It's okay if the patient breathes 20, they get 20. But if they fall to 14, it's going to start delivering some timed breaths that are not triggered by the patient. So you basically set a minimum number of breaths on this. And then, again, it goes to control mode. One of the problems here is that the patient's agitated or they get tachypnic and they're breathing fast for another reason, is every one of these panting breaths will now be a full breath. So if you've set it at, say, 500 and they're breathing 40, they have a minute ventilation of 20 right there because you've done this. So, again, this is one of the pitfalls to watch out for here is that when they're breathing fast for some reason other than high CO2, you can get into trouble. They can also, because it's so high and they're breathing so fast, get into what's called auto PEEP, which means they don't completely expel all the gas between breaths. So each one you get incrementally higher and higher pressures because you're not able to fully expel the gases at the end of the breath. But this, again, does the least work of breathing. Every breath the patient wants gets fully taken care of by the ventilator. So here you can see on assist control what the alveolus look like. Just each breath simply opening and closing. You can see how some close and some of these maintain open due to the PEEP. So SIMV, this is probably the most popular mode of ventilation. This has both mandatory and spontaneous breaths, which are synchronized, meaning all of this goes with the patient, again, unless they fall below a certain target, in which case the ventilator will kick in and take over. The mandatory breaths here are fully supported. So if you've said SIMV with tidal volumes of 500 for 20 times a minute, 20 breaths per minute will get that 500. If they breathe 25, those extra 5 breaths will be delivered in a pressure support fashion. So the spontaneous breaths, it allows the patient to do some work. This is good. You want the patient to do some work of breathing. When you're in assist control, your diaphragm wears out, you just lose your strength and your ability. SIMV forces the patient to do some work every now and then so they don't completely become reliant on the ventilator. This is most common again. So here you look at typical settings and how it's going to look. In this example here, you have, the peak airway pressure on the top. And in this example, the PEEP has been set at 5, so that's where that blue line is. Pressure support has been set at 8, and a tidal volume of 26 ml, it's been set by milliliters per kilogram over here, has been set. So on these, the rate is 20. On these 20 larger breaths, those are synchronized, intermittent, mandatory breaths. The patient will get that full tidal volume. Here in this case, they're doing 8.7 cc's per kg. On the breaths in between that are over 20, say they're breathing 30, they get a pressure support breath, which are the smaller, lower inflections. Again, all of these are synchronized to the patient. They get the minimum, the number you've set of full breaths, and then pressure support on the others. So they're having to do that work of breathing there. Comparing some of the modes, you see in assist control mode, the dotted line represents the typical sinusoidal pattern in and out. When the patient triggers, that full breath is delivered in a timely manner. In IMV, you can see that these large breaths are just simply delivered, marching out like the rhythm on a metronome. And then in SIMV, you can see that they fit better with that sinusoidal regular wave pattern. So on some of those triggered breaths, they'll get that full synchronized intermittent breath. Initial settings, you want a rate of about 10 to 14, tidal volumes of 6 cc's per kilogram. This is a number to remember. Probably when a lot of people trained, the number was 10. That proved to cause barotrauma and problems. So the low tidal volume or the lung protective ventilation strategy is 6 cc's per kilo. FiO2 should be about 100%, PEEP 5, and then pressure support if you're on SIMV, give them about 10. And this is a decent initial settings, and then you can titrate from there. Routine monitoring, you should have a pulse oximeter on at all times while you're on the ventilator. And then end-tidal CO2 can be helpful because you can continuously monitor how well you're ventilating or if things have changed. And so maybe you can cut down the frequency of blood gas analysis. Arterial line is optional. This, if you're checking up blood gas every few hours or frequent labs, ART line is very helpful in doing that. Remember not to put an A line in the brachial artery. This is an end artery, and if you have any arterial damage or occlusion here, you can lose a hand. So all the rest have collaterals. The brachial artery doesn't. So that's something to remember in terms of choosing sites for A lines. The Allen's test, as you recall, is putting pressure both radial and ulnar, and then releasing just the ulnar to see if the whole hand perfuses. Question, the mechanical ventilation mode that allows the patient to breathe spontaneously at 2 levels of positive pressure is known as what? Assist control, bi-level, continuous positive airway pressure, pressure regulated, volume controlled. So this is bi-level. Again, the stem is leading you down there. It's 2 different levels of treatment. So these are alternative and newer modes of ventilation. And this, the buzzword here is open lung strategy of ventilation. Basically, you have bi-level airway pressure release ventilation, which is just an exaggerated bi-level, and then the high-frequency oscillators for ventilation. Bi-level augmented form of pressure control ventilation. This allows unrestricted spontaneous breathing, and you're simply setting a P high and a P low. And it's got to be long enough at each of those pressures that the patient breathes spontaneously at both settings. And so they're just given those sometimes you may have a PEEP of 10, sometimes it may be 25. That gives you a mean airway pressure of the average of 10 and 25, 17.5, which is higher than usual. These can help to really keep the lungs open at all times. You can't keep the pressures high at 30 all the time because that inhibits cardiac return. But it gets you an overall average airway pressure that is higher using this mode. This can be better for the patient because they're really just breathing spontaneously at these 2 pressures, so they don't have to be as sedated. The breaths occur again at 2 levels of PEEP. You set the P high and the P low. Usually, when it's called straight bi-level, you set it about 50-50. So if you're breathing 15 times, your breath cycle is 4 seconds, 2 seconds at high pressure, 2 at low. Would be pretty normal. But you can breathe anywhere you want within the cycle. There's no volume settings here. There's no time. There's no specific timing. It's just that you have enough time to breathe at both. If they are breathing spontaneously, it's bi-level. So here you can see here is just the pressure diagram. You can see that it just oscillates from low to high, and then these different deflections are the breaths that the patient takes. In the first example at the left, it's synchronized, so that just means that the ventilator does its best to move between pressures with the breathing cycle, so it's a little more comfortable for the patient. Otherwise, it's just straight time-based. Again, the areas we're concerned about here, and you see a typical pressure volume loop here. With inspiration, you follow the green line going up, so as pressure increases, you see that it goes up to about 10 before any volume changes. Then all of a sudden the volume goes up, and it has both an upper and lower inflection point of where these begin to change. You kind of want to work within these 2 inflection points for the zone of safety. So airway pressure release ventilation is an exaggerated form of bi-level, but basically you've just set your high to be most of the time, and your low is set at maybe 0.5 to 0.7 seconds. So there's no real spontaneous breathing occurring at the low. It's just a passive release of the pressure in the airway to allow CO2 to escape in between breaths, but it's basically a way to maintain very high PEEP, except for a small fraction of the time. Again, P high, you set the pressure high and low and the time high and low. So this is more what it looks like here. You can see that basically the breath, instead of being spaced out equally above and below, is almost all at the high pressure with just the short half-second release to allow gases to escape. This is a setting where CO2 will accumulate and you can tolerate permissive hypercapnia. Letting the pH go down to 7.2 is fine. And that's expected and tolerable with some of these ARDS protocols and low tidal volume strategies. Sir?
There used to be real concerns about excessive levels of PEEP interfering with cardiac output.
Yes.
No longer.
Well, when you can keep it down here at 25 and you have these periods of release, it does not become as big an issue. It still can be a concern, but by doing these bi-level, you allow enough time and other things that you're getting enough cardiac. You're not just set at 35 a PEEP continuously. You're having these drops to 0 pressure to allow filling. Here you can see what APRV looks like. Again, most of the time is spent in this high position where the alveoli are all open, and then there's just a quick release and re-expansion. You can see that none of these alveoli ever completely close. And so this is the benefit here with ARDS, is that you recruit all of these alveoli and then maintain them in the open position to prevent injury. So then finally we have the oscillator ventilator. This is just really rapid. You can set these things at 300 or 400. They deliver a very small volume consistently, but you have this average airway pressure again. Lower tidal volumes at like 6 cc's per kilo, and a lower plateau pressure is achieved because you're just really moving a little amount of oxygen very rapidly. It does achieve gas exchange by the constant mean airway pressure, which is higher. Thus, you avoid that zone of overdistension where you're causing pressure and barotrauma, and that zone of complete collapse where you get the shearing forces. So again, this is kind of where these come in that zone. When you get to that zone of overdistension, you get injury to the alveoli, they get leaky, proteinaceous material buildup, surfactant starts to not work as well. In the lower zones, you get derecruitment, collapse of the alveoli, and then pressure trauma. In addition, if 50% of your alveoli are closed and 50% are open and you deliver that full breath, that breath is going to go to the healthy alveoli and leave the other ones closed, which means you've double distended the healthy ones and cause more injury. So you want to stay out of those zones. So you can see here that's the cyclic closing of the alveoli and then the high peak airway pressure that we want to avoid. So if you look here, here's just like one normal breath, and what we have superimposed over that is the oscillator that's just breathing, 10 times. It's cycling in that same setting of one breath. And that would look like this when you're looking at the alveolar level. Again, ventilation will be compromised, but oxygenation will maintain in a safer zone. Lung protective strategies include all of the following except tidal volume of 6 cc's per kilo, low PEEP, C, plateau pressure of less than 30 centimeters of water, or D, all of the above. Actually, I missed that. Low PEEP is not a strategy for doing. Remember, we want PEEP to be slightly elevated to keep those open and avoid the shear and distension. So higher, a little bit higher than normal PEEP is part of lung protective ventilation. The other two numbers, you do want your plateau less than 30, and you do want tidal volume of 6. So looking at ventilator-associated lung injury, there's both the overstretch, again, the stretch injury that causes inflammation and increased vascular permeability. These are the patients that get that white, fluffy bilateral infiltrates bilaterally that are not in pulmonary edema. That overdistension stretch is due to the excessive volume, maybe due to both the tidal volumes and the PEEP. Severe overinflation of normal alveoli leads to progressive injury. And then there's both a mechanical factor and a biochemical factor here. So in the overdistension, you can see the capillary transmural pressures change. The relaxation changes transmural pressures here. You can see that the capillary beds now in this overdistended blood are not getting there, so this is becoming more effectively dead space ventilation in those overdistended. And then you get all of the proteinaceous materials due to the leakiness of the alveolar cellular structure. At the low end expiratory volume and pressure where we don't have that PEEP, you get the shearing injuries and the surfactant dysfunction, and then increased regional overdistension. Again, when you have 50% of those in the lung are collapsed and you're not getting them open, all of your breath is going to be shunted toward the other normal alveoli, which will now become injured alveoli. Shearing injuries, again, repeated opening and closing of that alveolar unit. It causes regional differences in ventilation, and it worsens the surfactant slowly functions less and less, making it harder and harder to open each of those alveoli. So again, overdistension, edema, surfactant degradation up here in this high area with mechanical disruption, and again the de-recruitment and atelectasis that occurs, inflammatory, local hypoxia, and then overexpansion in the other regions. So lung protective strategies, and this is, we're going over this a lot because this is the latest buzzword in ventilators is lung protective ventilation. So again, all the strategies that go into that is to maintain the plateau pressure at a low level to avoid overdistension, and to apply small tidal volumes to limit the shearing forces. Again, tidal volume 6 cc's per kilo, plateau pressures less than 30. Optimized PEEP, which means give enough. Again, as you mentioned before, high PEEP can affect cardiac return and venous pressure, so you cannot maintain it too high. You get to a point of about 14 or 15, and now you're going to get hypotensive and not be able to rely on PEEP at a constant level. And then tolerate permissive hypercapnia. Which of the following have been shown to decrease ventilator-associated pneumonia? A, rotary beds. B, gut decontamination. C, silver endotracheal tubes. Or D, elevation of the head of the bed. That's right. Simple things. Elevation of the head of the bed. Just keep the head of the bed over 30 degrees at all times while you're on the ventilator, and you will have less pneumonia rate. All of these other antimicrobial covered tubes and the selective gut decontamination have been tried, and they didn't work. Simple, common things seem to help. Which is true about the diagnosis and treatment of ventilator-associated pneumonia? A, start with narrow spectrum antibiotics. B, best diagnostic study is quantitative cultures. C, MRSA is not a causative bacteria. D, chest radiograph plays no role. That's correct. The answer is B. The best diagnostic study is that quantitative culture. Sputum cultures are just about worthless in the ICU setting. They're almost always positive, and without knowing the numbers, it's not going to target you that well. You really want to get a sample down from the alveoli, whether that's directed through catheter drainage or a bronchoscope, either way. And quantitative cultures are much more helpful because we'll have a certain threshold for treatment. So looking at pneumonia and ARDS, pneumonia is very common in the ICU. Great morbidity and mortality, and it's about a rate of 3% per day of mechanical ventilation will increase. Very costly to the patients and to the system. So acute lung injury, ARDS, this is in about 5 to 15% of ICU patients. This is so much less common than it was, say, 10 years ago, 11 years ago when I trained, due to these better ventilator technologies, better ventilator strategies, better fluid management, all of these things. It still happens, though, and so there's still some tricks. Mortality rate is very high in this. The patients usually die of something else. It's not the lung issue that gets them. It's everything else that's going on that caused it. Multi-organ failure is quite common. So again, this is secondary to the capillary leak, interstitial edema, surfactant dilution, and then the inflammation. You change your cell type, and the type 2 cells in the alveoli are lost. Again, these produce surfactant, so you lose even more of your protection mechanism. There's an early exudative phase. This is that white fluffy infiltrate where the patient's just drowning in their own secretions. Then you get a proliferative change where the cells and the inflammatory response kick in. And then finally a fibrotic, more permanent phase that can occur weeks out. New infiltrate on X-ray is part of the diagnosis. Leukocytosis, fever for pneumonia. And then you get the bronchial culture. Regular sputum, again, not very accurate. Quantitative, you look for greater than 10 to the fourth to decide that it's infection and not just either a contaminant or just something that's just there but not causing any trouble. For acute lung injury, again, it's acute and it needs to come on quickly. It's bilateral infiltrates, and the P to F ratio for acute lung injury is less than 300. Moving on to ARDS, again, it's very much the change, but now the P to F ratio is less than 200. And again, pulmonary capillary wedge pressure in the old definition had to be under 18, because if it was over, you couldn't tell the difference between pulmonary edema and ARDS. Again, most patients don't have a PA catheter anymore to make this distinction. The P to F ratio of less than 200 is really what you want to see. In management pneumonia, start antibiotics early, immediately after obtaining cultures, initiate them, tailor to your unit and broad spectrum, and then tailor them as the results come back. Always consider MRSA and Pseudomonas if the patient's been in the hospital a long time. Depending on your ICU, you may want to double cover Pseudomonas depending on just what's growing, and this can be even in the same hospital. It can be different unit to unit. And then de-escalate when you can. You want to acute lung injury, ARDS, maintain adequate oxygenation. Consider some of these alternative modes. There's sort of a stepwise approach to this. You can use your FiO2, then increase your PEEP once that's failing to get you there. You might consider bi-level or an open lung ventilation strategy. Some other alternatives as you keep going down this road, once the ventilator is failing to get you there, paralysis can be used. What that does is decreases the chest wall component of resistance to breathing. The lung is still stiff, but now the chest wall is a little relaxed. Also, that can decrease some CO2 production. Proning has been shown to be of great benefit, and so if there's an option where everything you know is failing, putting the patient on a prone bed can be very helpful in ARDS and acute lung injury before paralysis. More than likely, there's a pretty significant degree of neurotoxicity later on if the patient survives from being on a long-term neuromuscular blockade. Again, things that people didn't used to survive them, and now that they do, we see that a year out, that can be problematic. The prone beds have their own thing. The patient's upside down. It's a little hard to access. They now have special beds made that allow your tubes and lines to work, because you can imagine as the bed flips and rolls side to side, tangling the patient in ventilator lines and IV lines can be a challenge. But with these beds, it can help. Again, also D-cubes. They're all in the wrong space because now the patient's laying on their face and down on their front side, so a lot of protection and padding is needed. Again, prevention, head of the bed at 30 degrees. Oral hygiene is the best method. These mouth cleaning systems should be used, chlorhexidine, 4 or 5 times a day. Daily sedation holiday and daily spontaneous breathing trials are important. Basically, every morning, if the patient is getting better, you turn the sedation off, turn it back on at half the rate it was if they start to get agitated, and in that time, assess their readiness to extubate. You do a spontaneous breathing trial. Other prevention may be early tracheostomy. The data is always out. One study will show that you cut pneumonia, and another will show that it's not that beneficial. So which of the following is the most predictive of extubation success? Rapid shallow breathing index of less than 100, negative inspiratory force, or how much suction you produce of more negative than minus 25, a PDAF ratio of greater than 200, or D, a successful spontaneous breathing trial. Again, what is most likely to predict success? That's right. The correct answer is a successful spontaneous trial. All these other factors can contribute to making that decision, but the best thing is just to see how they do breathing on their own. Let the patient tell you. So in weaning from the ventilator, there's 2 styles. They can be an SIMV wean or pressure support wean. In an SIMV wean, basically you set the patient on their normal SIMV rate, and every day you turn down the rate of those mandatory breaths, which means more of the breaths are just plain pressure support. So you eventually get down to the point where the ventilator's set at maybe 4 breaths a minute. Everything else is pressure support. And then they're doing almost all the work of breathing on their own. Pressure support wean is similar. You just put the patient on a straight pressure support. It may be at 20 or 15 to get the breaths. And then every few hours, you just slowly inch that pressure support down. Once you get down to minimal settings, say 10 of pressure support or 5, if they're doing okay down there and their gas is good, you can remove the tube. Either of these is a valid way to do this. Clinical parameters, the patient needs to be stable. The problem that put them on the vent should be resolved or in the process of resolving. On minimal support, meaning 40% oxygen, 5 of PEEP, and only 10 of pressure support, they ought to be able to breathe and maintain a normal blood gas. The things that aren't measured by these, by rapid shallow and other things, are the ability to protect the airway and handle secretions. So the patient needs to be strong enough to lift their head off the end of the bed. They need to be able to cough for you on command. And they need to not be requiring suction every hour by the nurse. That'll rapidly fail. Those are the things that are harder to pick up on some of these indices. Looking at some of the clinical parameters, basically what the point of this slide is the things that we accept as ready to extubate are nowhere near our normals. Normally PDFs greater than 400, we'll take half that. Tidal volumes, again, are around the normal. Respiratory rate has to only be really less than 25 or 30. And the minute volume needs to be just less than 10. The NIF, or the negative inspiratory force, normally you or I can generate more than 90 more than 25 is acceptable. Rapid shallow breathing index, which is simply the, as it sounds, rapid, so the respiratory rate divided by the tidal volume. So say if they're breathing 30 and it's 300 cc's, it would be 30 divided by 0.3. The index would be 100. A number greater than 100 or 105 is 70% predictive of failure. On the other end, having a normal RSBI is not as good as a positive tool, but if you're over 105, you're not going to fly, basically, for the most part. So best predictor, again, is the spontaneous breathing trial. You put them on 40%, 5 of PEEP, 10 of pressure support, you let them go for half an hour, and you get an AVG at the end to make sure it's normal. If they're doing that, if they start breathing over 35, having blood pressure abnormalities, arrhythmias, they just look terrible, their pH drops in that blood gas, that's a failed trial. Again, lots of causes that you can look for: agitation, anxiety, infections. You just need to find out what these are and see what you can do to treat them, whether it be better feeding styles, do they need an NG tube just because of stomach, is it just body positioning, etc. So that's about it. And again, the questions would usually be clinical scenarios that either suggest the patient should be intubated, or maybe you're presented with a case of the patient's on the ventilator and they're still hypoxic. What can you do? Or the CO2, and, you know, which of the following are techniques to get that normal and how to adjust that. Not so much picking whether you use SIMV or AC or pressure control. Again, very rare, and that's more a style practice pattern. For testmanship, it's, you know, what do you do to fix an acute problem, and when do you need to get this patient on? The latest buzzwords, again, lung protective ventilation, 6 cc's per kilogram, and the low tidal volume, and then spontaneous breathing trial, sedation interruptions. All of these are things that are considered good. So if you see those as choices, lean toward those. Thank you.